This is your last Diet 111 lecture video. We'll be looking at adolescence, childhood obesity, and nutrition in the elderly. Adolescent is a quick period, not many years, but a lot of changes, physically, emotionally, socially, intellectually as well. You can see there's a big growth bump, second only to the first year of life. This is the first time when nutritional needs differ between males and females because of the differing changes that occur during this growth period. Nutrition is extremely important to support all of these changes, and needs are relatively high, and you can see that here by the suggested amounts from each of the food groups. There are so many things that occur during adolescence that can impact nutrition, and some of them are listed on this slide. We've talked about this already just a bit. One of the changes that has occurred is that adolescents are drinking less milk and more soft drinks and sugary beverages, and this takes a toll on health. So as far as nutrients of concern, there are many. These are probably the top. Many adolescents, teenagers are low in vitamin D. Iron is a concern for both males and females, especially females starting their menstrual cycles. Calcium along with vitamin D is important for bones, and yet many teenagers have a shortage in terms of their intake. And zinc we haven't talked about a whole lot. Zinc is needed for growth and development, so zinc's very important as well. Of course, this is a period when peers become very important, a lot of influences outside of the home, and this is important for parents to understand. The link here will take you to a great little article on nutrition and teenagers. Definitely read it if you have teenagers at home, work with teenagers, or your subject for the last homework is a teenager. Read over the information here. You need grab-and-go food. They'll eat what's available, so make it relatively healthy. Again, you see the food groups required. They across the board need the nutrients in greater amounts as they grow older. We're going to kind of segue into childhood obesity. This also affects teenagers as well as children who are younger. And the statistics paint the story here. We have seen rising rates of overweight and obesity in children to a dramatic degree. So you see a doubling and a tripling of rates. A generation ago, it was rare to see children who were overweight or obese. Now it's actually very, very common. We've discussed this already in Unit 3 of this course, but there are many factors that play into those. Genetics is one of them. The mother's weight and nutrition during pregnancy plays a role as well. We talked about that a bit when we talked about pregnancy. And then all of the things that impact all of us. This obesogenic environment where high-calorie, nutrient poor foods are everywhere, and exercising is not the default. It's something that you have to build in, so many children are not getting enough exercise. Now, the consequences of childhood obesity are many, and I think this is important to look at for a minute. Sometimes people, because this has become almost a norm, that kids are heavier, that children are overweight or obese, sometimes there's this collective shrug of shoulders as if that's just the way it is. It might be the way it is, it may be the trend, but it certainly takes a toll on health. We see a multitude of problems that come about from this weight status of our children. They include orthopedic changes, not only Blount's disease, but certainly osteoarthritis, a joint issue, a wearing away of the cushion that used to only be seen in older people. We see non-alcoholic fatty liver disease because of the tremendous amount of sugary beverages that are being consumed, and this can lead to liver problems, including liver failure. We see type 2 diabetes in children. Back in the day, this was called adult onset diabetes. We never saw this in children. And now we're seeing rising rates. Look at this over the course of just 8 years of glucose intolerance, of type 2 diabetes in children. Be sure to read these links here. This is important not only for this class, but also for your future practice. This is a problem that you will be dealing with. So to emphasize why this is such a big deal with children, adult onset diabetes. In the old days, people of ages 50, 60, 70 may develop this. Now, from time of diagnosis to time of consequences, such as kidney disease and blindness and nerve damage and circulatory problems, depends on control, how well you manage your disease, but might be 15 years down the line. Maybe longer, maybe shorter. When you have a child who's diagnosed at 10, that puts them in the prime of their life when they're developing these problems. And hence we see things like strokes in young adults, high blood pressure, high blood lipids. This is not what we want to see in children. If you're thinking about how we diagnose this early, how we catch this early, acanthosis is one of the signs of insulin resistance, glucose intolerance, and you see this change in color and texture of the skin. It becomes darker and also kind of softer to kind of a velvety type of texture. This is a sign of insulin resistance. So when doctors and nurses see this in their young patients, they send them right away for blood sugar testing. We see now high blood cholesterol in kids, and we've talked about why that's a problem. We see high blood pressure in children. I want to take just a minute to discuss how this happens. Quite often I've heard indignant individuals talk about how this is the parents' fault. It's the parents' problem. They are negligent for allowing their children to become obese. And I will not argue that it's the parents' responsibility to take care of kids as best they can. But in the courses I've taught to children and families, I've met amazing parents, amazing, caring, loving, intelligent parents with obese children. So I wanted to describe from this graphic here how this may happen. So here's a healthy child. Not only is she healthy, but she's wonderful. She's never gives you a problem. She plays quietly and is happy. She does things like coloring and TV and plays with her dolls. So she's relatively sedentary. Now, because of that and the food environment, it's easy for the energy balance to go off kilter. So she's not burning the calories that she's consuming, and now she is mildly obese. Now at this point, you might start to worry, or the parent might start to worry, but family and friends and even healthcare providers sometimes say, oh, she's fine. She's just a little bit thick. She'll outgrow that. So you don't want to ostracize her. You don't want to punish her. You leave her alone. And then she becomes moderately obese. And now you know quite certainly that she should be outside burning more calories and not be eating as much. But you don't want to punish her, use food as a punishment, withdrawing food. And when you push her outside, it doesn't feel good to her. She hasn't developed the skills, she's out of breath, she's uncomfortable, and she comes back into the house. Now this progresses to severely obese. The parent is wondering where they can get the help they need. They're looking around for programs, and there we have it. So it sneaks up in a way, but it also sneaks up because we don't catch it really early, even in the healthcare system. take a minute to look at these silhouettes of a young man and tell me who you think should be talked to, the child and the parent. At what point, 1, 2, 3, 4, 5, does the nurse and the doctor need to have a talk about food and exercise, all those good things? So in my class, most students choose these two. Oops. Although some say all children should have that discussion, but most say here. And then when I ask them, well, where do you think doctors are having that conversation? Many of them say here. So the healthcare system's failing as well in picking up these children. A lot of doctors and nurse practitioners aren't real comfortable around the whole area of nutrition and obesity. Got a little link in here. Okay. This is an interesting one. It is advising against only using BMI, but looking at health issues, so you'll probably enjoy that. We might do this when we get together in our Zoom meeting, so I'm going to jump over this, and now we have to talk about nutrition and aging. So we're skipping over the adult years because the entire course to this point was devoted to your average adult. So when we talk about aging, there's really no way to prevent it. We're biologically programmed to age, and you can read about that in your textbook. When you talk about how the demographics have changed, we certainly have extended life expectancy, and we also have more individuals of the elderly years. There's a term called compression of morbidity that you need to be familiar with. You'll see this on a test. I think it's a great term, by the way. I'm not sure if this graph illustrates it really well, but this is what compression of morbidity means. Right now, we have individuals, especially with childhood obesity and Americans becoming less healthy, who develop health problems in their 30s and 40s and 50s. So they have many years of being encumbered by chronic diseases, by medications and limits on physical activity and a decreased quality of life. The healthcare system does well at keeping many of them alive, but certainly their life is not ideal in terms of health. Compression of morbidity means squeezing that period of illness into a smaller period. So ideally what would happen would be that you'd live healthy, live healthy, live healthy, live healthy into your later years, and then after a relatively short period of illness, you would pass on. That's compression of morbidity. We don't see that in many Americans. I would say maybe most Americans. So I have this amazing TED Talk, I'll link you to it in just a minute, that describes how we age and why we age in certain ways. And certainly it's multifactorial. Some is genetics, and we talked a little bit about that already. Some is environment, toxins, accidents, and quite a bit is based upon lifestyle as well. And let's see, there it is. Okay, so go into all of these links, but especially please listen to this TED Talk. This is a great TED Talk that looks at what are called blue zones, which are places in the world where people live long and healthy lives into their hundreds quite regularly while still riding bikes and building fences, very different from the United States. So I want you to take a look at that and tell me, perhaps in our Zoom meeting, what you learned from that as well. We also know, so this, you might see that on the test, we also know that caloric restriction extends life and delays disease, and we found that through epidemiological studies as well as laboratory studies with animals. You can learn about that here. All right, let's look at what changes with aging. Now, the number of these issues and when they occur differs from person to person, but it's not unusual, even in the healthiest of elders, to see some losses along the way. Physiological changes decrease function, so be sure to read through all of this. We see body composition changes as well. You should know what the term sarcopenia means. This is loss of muscle mass and strength with aging. It's illustrated here. This is a 25-year-old cross-section of a thigh, 65-year-old cross-section of a thigh. The white area is the fat, and you see that here as well. As we get older, our body shifts to less muscle, more fat, and of course, this also lowers our metabolic rate. Be sure to visit this link about depression, because they've shown that the DASH diet in seniors can actually decrease the risk of depression. That coincides very well with the research I've done on nutrition and brain health. More fruits and vegetables seem to lower the risk for depression. Depression's not uncommon with the elderly for all sorts of reasons. So when you see malnutrition, and again, please go into all of these links, it often spirals or snowballs into a number of problems. So you might see decreased muscle mass, and you may see a gain of weight. You may see decreased immune function and increased illness. You might then see more medications, which can also make things worse. It's just this big old snowball of things that occurs. As far as nutrient needs, interestingly, what you're looking at here in the green and the red are the needs for older people compared to the yellow, the needs for younger adults. And you see that older people need as much, if not more in some cases, of the vitamins and minerals, with only one exception, and that's iron for women, of course, because of menopause. So it is false to think that older people, they're old, they're not doing as much, they don't need the nutrition. They absolutely do, but they need those nutrients in fewer calories, which sets up a bit of a challenge. Most older people have a lower body basal metabolic rate. They have a lower activity level as well, so calorie needs decline with aging. And yet, remember this, nutrient needs don't decline with aging. Protein needs are the same or maybe higher. There are a lot of experts now, and your textbook lists this as well, that believe elders should consume closer to 1 gram protein per kilogram instead of 0.8. Don't want to go overboard on fat, because fat can take away from appetite, which is already a problem with many older people. Need the fiber to prevent constipation. In seniors, there is often an issue around constipation caused by low activity, not enough fluid, not enough fiber, medications, and just a slowing of the GI tract. Water becomes hugely important. The number one reason for confusion in hospitalized elderly is dehydration. And seniors are at a risk for this, senior citizens, because they don't get the thirst trigger as easily, so they don't feel thirsty, and yet they have less total body water, and their kidneys are not as efficient at holding on to fluid when needed. Dehydration can be very, very serious, and you see this here. Vitamin D, vitamin B12, folate, we've talked about these essential nutrients and the special issues with the elderly. Certainly vitamin D may be low in the blood because of less exposure to sunlight, the skin being less efficient at converting, the kidneys being less efficient, consuming less vitamin D as well. Vitamin B12 can be an issue because of a lack of intrinsic factor or stomach acid. and folate can be a nutrient of concern. Here are a few minerals that are also of concern. Note zinc. We talked about zinc with teenagers being important to sexual development. In older people, it's very important for taste, and it's very commonly low, which would be one other reason why a multivitamin designed for older people is not a bad idea. Eating across the spectrum of food groups is important, and yet if any of you have chosen an older adult for your subject, they vary tremendously. I've seen some homework assignments where the seniors are eating better than their grandchildren, and others where their diet is really lacking. I love this from Tufts. Tufts University does a lot of research and education on nutrition and the elderly, and I really like the plate they put together because it is focused on the elderly in terms of things that are easy to store, low in cost. So you can see here there's nothing wrong with frozen vegetables if perhaps they're fresh spoiled too quickly. There certainly is nothing wrong with some lower sodium beans or nut butters as a source of low-cost protein. So be sure to read over this. And physical activity still is recommended for most older adults. It's really, really important for both mind and body. That is essential. Keeping active, keeping engaged is good for physical and brain health. Drugs are very common. Many older adults are on a number of prescriptions, and it becomes complicated because these can have interactions with each other, with food, cause problems around digestion and nausea and diarrhea, etc. So you really have to understand your medications as a nurse. Okay, before we close, a couple of last topics that I think are pretty exciting. First of all, let's look at how nutrition affects some of the major problems in aging. So we'll talk about the visual issues first, things like cataracts and macular degeneration. What we've seen around these is that risk factors are oxidative stress, number one, and obesity for cataracts. Oxidative stress is the damage caused by free radicals, and it's lessened by antioxidants. So here you see fruits and vegetables are really, really important for preventing a decline in vision with aging. Fish is important to bring down inflammation. Weight should be managed. Stay away from the carbohydrates that raise blood sugar quickly, and take an ordinary multivitamin and mineral. B vitamins seem to help. As far as arthritis, be sure to look at this because it talks about oils. What we see with osteoarthritis, the most common cause, the wear and tear arthritis, is that overweight can worsen this, so weight loss might be helpful. And exercise kind of juices up these joints. So exercise, carefully performed, and certainly with good recommendations by your physician or physical therapist, can be helpful in relieving the decreased mobility, increasing mobility, and decreasing discomfort with arthritis. With rheumatoid arthritis, this is an autoimmune disease, we found that shifting the oils can have an effect on the symptoms. So consuming more of the healthy omega-3 and less of the unhealthy oils. So be sure to read that link. Now, finally, the aging brain is a special concern as we have more and more baby boomers reaching this age bracket. And we have some great research around this. So let's talk about cognitive decline. It's not an uncommon thing, and it's hitting us like a storm with all of the older people now, that dementia is becoming almost something similar to an epidemic. So dementia can be caused by Alzheimer's disease, which you see here, these plaques and tangles are seen in Alzheimer's disease. It also can be caused by vascular issues. So when someone has cardiovascular issues, they often have issues with the carotid arteries that supply nutrients, oxygen, carry away waste from the brain. So vascular issues, cholesterol issues, and free radical issues can hasten cognitive decline. To keep the brain healthy, there are a whole list of things you can do. Let's look at the food items first. Eat fruits and vegetables, antioxidants, omega-3 fatty acids. Watch your calorie intake. Be sure to exercise, stay engaged, occupied, challenged intellectually, puzzles, reading, book groups, etc. And also, don't go overboard on alcohol. And if you have a chronic illness, manage it, for goodness sakes. There is actually a diet for slowing cognitive decline and decreasing the risk for Alzheimer's, and it's called the MIND diet. And you can learn about some aspects of it here for sure. This is the MIND diet. This is a simplified version of it. Very easy. It's a Mediterranean dash intervention for neurodegenerative delay. A mouthful, and that's why we say MIND. And what we're looking at here is what we know is protective of brain health. Also, avoiding those foods, those ultra-processed foods that have a negative impact on brain health. Because nutrition is so important, it's also vital that we are able to target those individuals, elderly individuals who have food insecurity. This is a tool that does that, and there will be one test question on this, and you see disease, eating poorly. The acronym DETERMINE actually looks at the warning signs of malnutrition. So it helps us to recognize that these things increase the risk of malnutrition, and when you see more than one, that increases the risk further still. So this type of checklist is informative, but it also is helpful to have on hand at a senior center or a long-term care facility, perhaps. Excuse the beeps there. We also have other resources for older adults that include the Older Americans Act. Meals on Wheels is handled by that. It's a great program, and so are the congregate meals that are served at places called senior centers. These aren't adult daycare. This is different. This is free living, independent. Seniors come in for a meal and games and activities, etc. And those meals become very important not only for the nutrients provided, but also for socialization. Now, long-term care is a different story for a number of reasons. We see residents who are sicker. We often see residents who have cognitive decline, and therefore the risk of nutritional problems is higher for all of the reasons we've talked about so far, plus the increased sickness and cognitive decline of these residents. But we also need to consider what else is happening in long-term care. You may have understaffing, so you don't have enough staff available to feed residents who need it. You may have unappetizing food. You may have an environment that is not conducive to eating, things like dark or dingy or smelly or loud. So if you ever work in long-term care, remember that these elderly individuals come with a lifetime of experiences and preferences, and even when there is cognitive decline, you can throw them off their game at meal times with those type of environmental situations. So you need to pay attention to that. Keep in mind also with elderly people that nutritional needs may be increased even more than those younger because of things like infections, which are not uncommon, and also decreased absorption and increased losses. So we will get to this at our Zoom meeting, but you are officially finished with your lecture videos. Good for you.